Good morning, everybody. My name is Sara Dugan. I'm a mental health pharmacist at NeoMed. I am joining you today from Tennessee, so from the Smoky Mountains. So happy spring, happy April. Our presentation topic for today is food and drug interactions. Our objectives are to describe how food and drug interactions may interact, to list foods and medications that may result in interactions, and to identify some steps to address what can be done about these interactions. To start off, why focus on food and drug interactions? There are well-established interactions between foods and medications. In some cases, individuals really prefer foods to be their treatment. Eating disorders is a great example, but there are other cases where foods can be used to assist with treatment of some of the conditions. And so it shouldn't really be a surprise to any of us that there could be interactions with their other drugs. One of the reasons we do need to be mindful of this is, while in some cases right here in the middle, there may not be a change. So individuals take drugs all the time. They're prescribed by their physicians, they eat their regular diet, and we don't see any problems. But there are instances where the foods that are being eaten actually could result in increased toxicity, sometimes just side effects where patients don't feel very well, but in other cases it may result in pretty significant changes in drug concentrations that may require hospitalization. On the other side, there are cases where foods may interact with the drugs that patients are taking, and it may make them ineffective. So we no longer have efficacy for the treatment of whatever the condition was that the patient was being treated for. So whether it's depression or anxiety, maybe it's for aggression or seizures or blood pressure, diabetes, any of these things, we could potentially make those medications much less effective. So it is something that's helpful to keep in mind. Looking at specific diets, so in addition to specific foods, which we'll look at a little bit, if we look more globally at the diets that patients are ingesting, for those that may be on a high-fat diet, so high-fat diets can slow gastric emptying, so it could delay the time that some of the medications take effect. So duloxetine is a good example. Cymbalta is one of the antidepressants that we can use, and the time to see an effect from the medication, if somebody's eating a high-fat meal, actually could increase from 4 to 6 hours to 10 to 12 hours. So we could see a significant delay before we see the effects of that medication. In some cases, it could alter the amount of the drug that gets absorbed. For mental health medications, it actually may increase the amount of drug that gets absorbed because they tend to really like the fatty type substances, which is good because we want them in the brain, which is really lipophilic, where there's a lot of fats. But that could be problematic for some of the other medicines that could be taken for other conditions. High blood pressure could be taken for diabetes, could be taken for their asthma or allergy condition. So just something to keep in mind, that while it might be good for some medicines, maybe not for all. It could also result in diarrhea. So diarrhea will decrease the transit time. So things that are in your gut actually aren't going to stay there for a long period of time. And there are some medicines that we use that may need that period of time to be able to be released. Some of our ADHD extended release preparations, things like Concerta, actually need that time to release the medication. If it doesn't have enough time, then we're not delivering enough of the drug, so they could potentially be underdosed. Looking at high protein diets, these could potentially alter transporter activity. So we'll talk about transporters more in just a little bit, but that's really how the medicines get into the body from the gut. So if they're mainly being used to absorb the protein from the diet, then they can't be used to absorb the medications, and that might be problematic. They also could stimulate some enzyme activity. So enzymes are proteins that break down drugs. And if we have more of that activity, then potentially more of the drug gets broken down and we have less of it to be able to act the way that we want to. Now, this is not to say that patients can't be successful on high fat diets or high protein diets. There are some individuals who, especially with epilepsy, may be using ketogenic type diets. That's completely fine, and the body will adjust to that. But if there's an abrupt change in diet, then we may see a change in either side effects or loss of efficacy if the patient's on existing medications. So if they're on the diet to start with and we add medicine, then maybe we're not going to see as much of a problem. If we're moving to this diet, then we may have to do some closer monitoring to make sure that we're not putting a patient in danger. So let's look at the specific food and drug interactions. This is not all of them. I have a didactic blitz. I don't get to spend a tremendous amount of time. We could probably do a couple-hour lecture on this particular topic. So I picked some of the more common ones. We have 3 specific buckets that we're going to talk about in a little bit more detail. So the first one are food and drug interactions, and this is more of a generic category. The second one is changes in pH. So the fact that an individual is eating when they take their medicine, as opposed to eating, taking their medicine on an empty stomach. This would be some of the changes that we could see here. And then the gastrointestinal transit time. So that's the time that substances remain in your GI tract. So for patients that have constipation, that transit time might be much higher. For patients who have diarrhea, that transit time may be much lower. And we'll talk about some of the changes that we could see in both of those directions. So starting off, we're going to look at the absorption of medications. There are a number of drugs that can be used that specifically state that they should or shouldn't be taken with food. For some of our mental health medications, things like Latuda or lurasidone and Geodon or ziprasidone are 2 relatively well-known antipsychotic medicines that do have instructions to take with food. For the lurasidone, the suggestion is to take it with at least 350 calories. So a pretty significant snack or a small meal or a regular meal. So at least 350. The reason that they want the lurasidone taken with food is because when there is food in the system, more of the lurasidone gets absorbed. We can see twice the amount of exposure of the drug. So for the same dose of lurasidone, you can get double the exposure if the drug is taken with food. And we can achieve higher concentrations. So if we really want to ensure that we know the effect that lurasidone is going to have, maybe we're using it for bipolar depression. If we're not taking it with food, we're not getting the full benefit. We're not getting the full exposure of the patient to the lurasidone because we get lower concentrations. They're not getting as much of the drug into their system to be able to work on the neurons and help with those bipolar depression symptoms. So this would be one of the medications where it would really be helpful to know what does a patient's schedule look like. So if you have a teenager, for example, they may not have a huge breakfast. That may not be one of their larger meals of the day. It may be beneficial to move the lurasidone to an evening time. We know that they eat dinner. It tends to be a larger dinner. So we'll have them take their lurasidone in the evening or at bedtime. If they're eating right around bedtime, that would be a better option than having it taken first thing in the morning. That could really help us ensure that they're exposed to the maximum amount of lurasidone so we can evaluate whether or not that's going to be effective. For ziprasidone, its prescribing information says take with food. This had traditionally been at least 500 calories. In this case, it really wouldn't be a snack for the most part. This really should be taken with a meal. What they found is the total bioavailability, so the amount of drug that's taken that actually gets absorbed. So if you have a 100 milligram dose of medication, the bioavailability is how much of that 100 milligram actually gets into the body. If we're doing it IV, and there's an IV line, 100 milligrams, we inject it, 100 milligrams goes right into the body. When we take things orally in the gut, other things happen. So it doesn't tend to often be 100% if we take medicines orally. If we take the ziprasidone with food, we could get 60% of that dose. My example was 100 milligrams, so that means 60 milligrams would be absorbed if we take it with food. It would be probably between 25 and 50 milligrams that would be absorbed if the patient takes it on an empty stomach. Now, this one I do want to take just another smidge of time. Ziprasidone tends to be dosed twice daily. At the outpatient mental health clinic that I worked at, there were patients who didn't eat 2 meals a day. Yes, they were taking their medicine twice a day, but that first dose likely wasn't getting absorbed. Not much of it was getting absorbed. So we did have to look at changing the way that they were taking their medicine. In a few cases, we had them take both of the doses all at once. So we had them take it if they ate lunch, then with their lunch, if they ate dinner, with their dinner. Trying to make those adjustments to get the most out of the medicine. Again, it would be really helpful to know what the patient's dietary habits look like so we could make sure that this fits with them. We do want them to get the most out of that. And if the only way to do that is to get twice the amount of absorption with the meal and they're only eating a limited amount, then we need to work within those parameters. This is information that came from the psychopharmacology bulletin, and they were looking at the amount of absorption with different types of food. And what they found was compared to fasting, when a patient took the ziprasidone, either a 20 milligram dose, a 40 milligram dose, or an 80 milligram dose with food, 48% more was absorbed for the patients on 20 milligram. They were measuring the concentrations of the ziprasidone, so to see how much drug the patient was exposed to. And that's what that area under the curve means. So the patient was exposed to 48% more when they ate for just the 20 milligram dose, 87% more when they were on the 40 milligram, and over 100% more when they took the 80 milligrams. So a real significant change in the amount of ziprasidone that they were exposed to. It is important that we know if the recommendations are to take it with food because it could just upset your stomach. Some of our other antipsychotic medications, things like risperidone, things like olanzapine, so your Risperdal, your Zyprexa, even your Abilify, they're recommended to be taken with food so patients don't get nauseous or vomit them up, which we don't want either, but it's not because of this absorption issue. So there is a slight distinction there. Those, if they're not taken with food, they could still be effective. Maybe the patient's not as comfortable, but here we might really lose some efficacy. So those would be two examples of absorption of medication problems. Another example is the binding of drugs. This isn't quite as linked to mental health medications, but still could be a major problem for your patients. There are cations. These are positively charged ions. If you think of the periodic table, they tend to be on the one side and they would have 2 pluses when they're out. This means they can react with a whole bunch of different products, including medications. Some of the drugs that are well known to bind to aluminum, calcium, iron, or magnesium are some of our antibiotics, things like ciprofloxacin, and then some of our tetracycline. So tetracycline, minocycline, doxycycline, all are potential options. If they're taken, for example, with a glass of milk, the calcium in the milk will actually bind to the antibiotic and it'll never be absorbed. It'll continue to pass through the GI tract and will have no efficacy from that. For that reason, we really recommend that these medications be separated at least 2 hours for the antibiotics from any type of dairy product. That way the gut has a chance to break down the antibiotic. It has a chance to absorb it, get it out of the GI tract before any of the calcium dairy products. With iron, it could even be any of the meat products get exposed in the GI tract. For the bisphosphonates, you may not have a lot of patients who are on these. These are medicines like Fosamax that have been used for treatment of osteoporosis. These bind to most foods. Some of them are the dairy foods, but it really could bind to anything. And it makes the bioavailability less than 1%. So we would essentially make this medication useless. That's why it's recommended that it's given 30 minutes before any type of food with a full glass of water. We have to separate it so that the body has a chance to absorb it before any food gets in there, binds to the medicine, and the medicine just passes through and doesn't do anything. So these would be examples where when you're educated on not using them, we really must make sure that those are separated, because it would completely render these medications useless. The infection couldn't be treated. The osteoporosis, trying to build back up the bone so that we don't have any fractures, would not be treated either. This would be an elimination step to try to make sure that we separate those, definitely. Our next set of drug interactions are looking at some of our transporter or enzymes. These are going to be, the binding one is nice because they bind together, we have to separate them. These get a little fuzzy, a lot more in the gray territory. Our transporters line our gut, and they're pumps that move the drug from the gut into the body. They also could move broken down food into the body. So those transporters can be activated when a patient eats. In some cases, that's a good thing. The transporters turned on, it means that now the medication can be absorbed to a greater extent. In other cases, it may be that the transporters are turned on, but we're not getting enough drug in there, and it's competing with some of the foods that we're not able to absorb much of the drug because the food gets in the way. So there are instances with some medications, in some cases, things like chemotherapy medications that are taken orally, that may be less effective if they are taken with food. And that's why the transporters preferentially absorbing the food so that it has nutrients for the body and it's not getting the drug. But in other instances, so gabapentin is a great example. Gabapentin needs some amount of food in the body because it uses one of the transporters to get absorbed. But if it's a high protein diet, then the protein gets taken and not the gabapentin. So food can be a good thing, but it really depends on what type of food, and it can move in a couple different directions. The dose of gabapentin also, those transporters can only absorb so much. So if we get a dose that's much higher of gabapentin taken all at once, then we're not likely to absorb as much of it as we do with some of the lower doses. There's only so many pumps, and once we get them saturated, there's nothing else we can do there. In that case, it really would be helpful to be watching, what does the patient's diet usually look like? When do they plan on taking these medications? Then what do we see? Are there side effects? Are we not having efficacy? So we can make adjustments from there. It's really difficult to be able to predict ahead of time what would happen. On the other side of this slide are enzymes. These are the proteins that break down the drugs. These can actually be inhibited by or activated by proteins, but inhibited by some other medications. You may have heard some of the warnings on the commercials on TV to avoid taking grapefruit juice. There's a chemical in grapefruit juice that can turn off these enzymes. So if these enzymes aren't breaking down some of the medicine, then we may get much higher concentrations than what we would have expected. Oh, and that line got pulled off. Some of the medications that have been involved with this include some of the benzodiazepines. It's most commonly associated though with some of our cholesterol medicines, like the statin medications. We would get higher concentrations because it's not being broken down, so we might see some of those side effects. It would be best for the grapefruit juice if we're able to limit that. Maybe once in a while, but really if we could avoid that, that would be preferred. If that's something that's part of the diet, it really is non-negotiable, then we can make adjustments. We'll have to start with a much lower dose and then watch for adverse effects as they happen. Again, with the amount of protein, so protein can stimulate the enzymes, it means that more of the drug would get broken down and we wouldn't see as much of an effect. If we know that that's the case, we might start with a little bit of a higher dose and then monitor to see if we need to make further adjustments. So both of these a little bit more wishy-washy because they could go in different directions, but having that information can be really helpful. The next category was looking at really the acid-base status of the GI system. So the pH, or how acidic or basic, we have quite a bit of fluctuations that happen in our stomach as well as in our small intestine. The stomach tends to be the area where things get broken down. So the tablet or the capsule that you take can get dissolved and it gets mixed up in all of the juices and everything that's there. And then it gets moved into the small intestine, and that's where most of the absorption occurs. We tend to have a much more acidic environment right before we eat, or if we're in a fasted state, it tends to be a little bit more basic or closer to neutral in your stomach once you have eaten, because the food helps neutralize that out, but we're pumping acid in like crazy. Drugs are chemicals, so the amount of acid that they're exposed to could actually break them down a little bit. If they get ionized, so if they break off little parts of the drug and now the drug has a positive or a negative charge, it's much more difficult for a drug with a positive or negative charge to get into the body. One of the body's barriers is this lipid bilayer. So it's a fatty layer. And here's an example on the bottom, the outside of the cell and the inside of the cell. Then we have two layers of really fats that help protect the body. They keep a lot of water out. They keep a lot of other potential toxins and things that we don't want in the body out. It can also keep some of the drugs out, especially if they're ionized. If they have that positive or negative, those fats are not going to want to let them through. They would have to use a transporter, and not all drugs can be moved by transporter. So depending on if the patient has eaten or not eaten, we could see dramatic changes in the amount of medication that gets absorbed because of this particular factor. The body will adjust for this. If the patient if I'm on fluoxetine, so I'm on Prozac, I start taking it, I just can't tolerate it. It upsets my stomach. I have to take it with some food. If I take it with food all of the time, then my body will generally adjust to the amount of medication that we get in there, and we can make further adjustments. If it's not enough, we can bump the dose. But it's most important that I'm taking it the same way so that these factors can be accounted for in how we evaluate what's going on with the patient. There are other instances where we're trying to use either the enzymes or some of this ionization to break apart a medication. So maybe we have medicines that would be really sensitive in an acid environment in your stomach. They'd start getting broken down before they even get to the intestine, so we can't absorb the drug that we want. So in those cases, we make what's called a prodrug. We add something to the drug that then gets attacked when it's in maybe those acidic environments, but the drug itself was relatively protected and can move on to the intestine to get absorbed. And that's what we see with our yellow drug oval here. So we attach something to it. The enzymes or the acid are the little lightning bolt, and then we're able to get just the drug. It was somewhat protected. It wasn't the first step that got attacked by the body, and we're able to get that intact drug to the small intestine to be able to get absorbed. Those can be changed based on how acidic the stomach is. So in patients who may have stomach issues and they're on medicines, ranitidine, they're on famotidine, they're on Prilosec, those type of medicines may change the amount of acid that some patients are exposed to. That could change how much of the active drug we're actually able to get for that patient. Again, just knowing all of the medicines that a patient's on, how often they're taking some of these things, we can make adjustments for it. Maybe it wouldn't be the best option to go with a prodrug. Examples of that, Vyvanse is one of our prodrugs that we have. So it gets broken apart and then the stimulant is released so that it can be absorbed. That was done not so much for an absorption issue, but more for preventing the immediate action of those stimulants so that it's not misused as much. But that is one of the examples that you may come across. So a couple different issues that could happen with how much food is in the body, as well as what that environment looks like. One of the last considerations that I'm going to throw out for you this morning is changes in gastric transit time. You get food that goes into the stomach, it then moves to the small intestine, into the large intestine. When food is in the stomach, it does slow the gastric emptying time. So the time that a drug, if we take just a drug with a glass of water, it'll be in the stomach a little bit, but it'll move relatively quickly into the small intestines. If we have food that's in the stomach, it's going to take some time. It needs to get broken down so that it's in a format that could be absorbed well by your small intestines. Recognizing that when we take drugs with food, it changes the amount of acid that they're exposed to. So it could break down that medicine, or it could activate it like we just talked about. And we can also slow things down. So it's going to spend much more time there. We may have much more time in the intestines as well. In some cases, that may be a really good thing. We talked about gabapentin. It needs those transporters, but there's only a couple spots that those transporters actually exist. So if it's not going quickly, then it can spend enough time by those transporters to get pumped into the body. In other cases, there may be medicines that, because they were really kind of stuck in the acid for a longer period of time, they may get broken down a lot more. Maybe now they're ionized, so they're not as able to be absorbed by those transporters. So in those cases, it may be better to take it on an empty stomach if possible. For a number of the benzodiazepines, this is true. For some of our seizure medicines, so lamotrigine, phenytoin, carbamazepine, those can be affected, Depakote, those all could be affected by the amount of gastric emptying as well as what that acid-base environment is. So knowing that, recognizing what the patient needs to do to be able to take the medicine. If I'm taking Depakote, which sometimes can be really tough on the stomach, and I just can't keep it down, I vomit it if I don't take it with food, then we just make adjustments. You have to take it with food. This is what we're seeing. This is how much your body is able to absorb of this. Now we can make adjustments as we go forward. Sometimes it's a little higher than we expected. Sometimes it's a little lower than we expect, but we just want to be doing the same thing consistently so that we can make those adjustments. The last piece is with the transit time. So in patients who have constipation, we may be absorbing almost all that we could possibly absorb from those drugs because there's a lot of time that the drug spends in the intestine. In patients who may have more chronic diarrhea problems, it may be a lot less time. So there may not be enough time to absorb the medication because that drug's moving through the intestines relatively quickly. For some of our extended release preparations, this could be really problematic. Things like our stimulants, a lot of our extended release stimulant preparations, that may be a problem for them. The immediate release, in some instances, we have capsules that have immediate and delayed release beads in them. Maybe we get half of the dose because the immediate release ones dissolve, but we're not getting the full dose because the delayed release ones just don't have time to be able to dissolve. I talked about Concerta. Concerta is a pill where the very outside dissolves for an immediate boost, but then the shell doesn't dissolve at all, and there's a laser drilled hole in there. We want water to get in there, and there's almost like a sponge. It's gonna fill up once it gets exposed to water and push the rest of the medicine out. If it's moving quickly through that GI tract, it's not gonna have a chance to really deliver that medication. So we might see a lot less efficacy than what we would expect. This could be true for regular medicines as well. I had a patient who was on paliperidone who had chronic diarrhea that was a component of her PTSD, and we would have dramatic fluctuations. When she was having a lot more diarrhea, she would have a lot more other issues, and her paliperidone level would decrease pretty significantly. We can't just add things like fiber. In some cases, fiber actually will bind to the medicines themselves, and then we're not going to be able to absorb it because it can be kind of a gummy type substance that's supposed to bulk things up. It's doing its job, but it'll grab whatever's in the GI tract, and sometimes that is the drugs that they're on. So knowing that we may need to make additional adjustments Perhaps it's looking at other formulations. Are there other formulations that we could use that maybe are transdermal, that are injections, that aren't going to necessarily be oral? So recognizing the bowel habits can also be incredibly helpful. And sometimes this is linked to what patients are eating, especially if they're changing their diet pretty significantly or having high fat diet, high fat meal a couple times a week. Those might be days where we're not seeing as much efficacy. Maybe it's on Friday and Friday is pizza or fast food day. And then over the weekend, we struggle a little bit to get things back under control. Maybe we can make some adjustments for that if we know that that's coming. In general, we can see a lot of changes in patients' drug levels based on what their dietary habits are. Food definitely impacts the effect of drugs. Sometimes it's more side effects, sometimes it's less efficacy, sometimes we don't see a change at all, but really being attentive and monitoring that, watching for variability that exists. For a number of individuals, you have a great relationship and you might be able to pick up on some of those patterns, but also encouraging the discussion if there are going to be changes in dietary habits. So we can put together a monitoring plan. Maybe we can't predict what's going to happen, but at least so we're a little bit more proactive to help patients in the meantime. With that, I will stop share. So thank you very much for your attention today.